Hi, I'm Dr. Brad Neal, physiotherapy lecturer at the University of Essex, here today to discuss current best practice for patellofemoral pain in 2021, and you're listening to the Physical Performance Show.
Failure is not an option.
I've had my ups and my downs.
I think it's an absolutely breakthrough experience.
Welcome to the Physical Performance Show, the show designed to inspire the pursuit of your physical best performance. I'm your host, Brad Beer. Listen in as we delve into how the world's top physical performers achieve their success, as well as the highs, the lows, and the journey of getting there. Let's get ready, set, let's go. Welcome to episode 296 of the Physical Performance Show, brought to you by Polar's world-leading heart rate monitors and GPS watches, including the brand new Polar Red Vantage V2 watch. Polar's best just got better. I'm Brad Beer, sports physiotherapist and exercise scientist by trade and training, and founder of Pogo Physio. Each week we'll bring you the latest and greatest information and inspiration designed to help you perform at your physical best. Of course, we do this across a range of our different episodes: interest editions, coaches' corners, learnings catch-up episodes, featured performers, and our very popular expert editions. And hot off the back of last week's expert edition featuring return guest, high-performance consultant Dr. Tim Gabbett, who shared around considerations for training load progressions for both youth and adult athletes, we're exploring today a very important topic for any endurance athlete, and that is navigating kneecap pain, aka runner's knee, or patellofemoral pain. Now, we last explored the treatment and management of patellofemoral pain back in June of 2018 with Australian-based physiotherapist and researcher Dr. Christian Barton. Fast forward to 2021, and today you'll learn from UK-based specialist musculoskeletal physiotherapist and lecturer at the School of Sport Rehabilitation and Exercise Sciences at Essex University, Dr. Bradley Neal. By way of bio, Bradley has greater than 15 years experience as a physiotherapist working in the NHS, in elite sport, and the private practice setting, serving in the role of Head of Research at Pure Sports Medicine, one of the UK's leading sports medicine groups. Brad completed his PhD investigating the influence of lower limb biomechanics on the development, persistence, and management of patellofemoral pain in recreational runners. Now in full-time academia, Brad and his colleague, Dr. Simon Lack, are educating the therapy world on how to best manage patellofemoral pain through their collaboration, Team Patellofemoral Pain. And during today's expert edition, Dr. Bradley Neal will recap on what patellofemoral pain is, the current understanding of the aetiological drivers, differential diagnoses around the front of the knee, the top 5 mistakes to avoid when trying to get on top of your own patellofemoral pain, or for the therapist, the top 5 mistakes to avoid in treating patients with patellofemoral pain, specific tips for runners with kneecap pain, and as usual, our guests will challenge us with a great physical challenge and a top tip. There's plenty of learnings in this one. Enjoy Dr. Bradley Neal on this review of patellofemoral pain best practices. Get your pen and paper ready. Dr. Brad Neal, all the way from the UK. Welcome to the Physical Performance Show.
Thanks, Brad. Thanks for the invite. Thanks for having me.
Brad, this is a topic that we have explored several years ago with your PhD supervisor, actually, Dr. Christian Barton from La Trobe University here in Australia. And that is this topic of patellofemoral pain or kneecap pain. And as fellow clinicians, it is a doozy. So we've wrestled you on to bring us up to speed with what's changed since Christian Barton shared in 2018. So welcome to the show.
Thanks, mate. I'm slightly worried about the size of those shoes that you're trying to ask me to fill here, but I'll give it a go.
Well, I mean, Brad, just to paint a picture of your current working life, before we press record, you mentioned that you're full-time in the academic space now, lecturing, researching, etc. So what has brought you to this point, and Why the interest in kneecap pain, patellofemoral pain?
I'll answer the first one, the second question first. People often ask me this, and I haven't really got a particularly interesting answer, really. Like I started out my kind of early academic work was kind of centered around the shoulder. I went to university on a swim scholarship, so I stayed at uni for a little bit longer than the average physio graduate here in the UK. Went straight into a master's, and purely because I was still swimming, it made sense to do something around the shoulder because that's generally what swimmers grumble about, and I could recruit all of my buddies to participate. And then had a period of time where I wasn't particularly research active, and then just organic, really. I'd always had a greater interest in sort of insidious or gradual onset problems. Started working for Pure Sports Medicine, met Christian, met Simon, met Dylan, sort of decided I was going to embark on a PhD journey and was keen to do something in that space of gradual onset pathologies, and then went to a couple of different conferences and just landed on patellofemoral pain, really. I haven't really got a more interesting story than that, really. And I'm not plagued by it myself, nor was anyone that I cared about before I started the journey.
Well, it's quite interesting. The swimmer that now is a world leading authority on kneecap pain, otherwise often known as runner's knee.
Yeah, and swimmers don't generally get knee pain. You know, there's this big misnomer that breaststroke's bad for your knees, but I don't think I've ever met a high level swimmer that struggles with knee pain at all. And then, in terms of where I am now, you know, it was a wrench for me to leave Pure Sports Medicine and step out of the clinical arena. But my motivation was, I've got so many questions that I'd like to try and answer, and particularly at what I describe as being the two ends of the spectrum. So I've got a big interest in why conditions start, and I've got a big interest in why particular treatments may work, and the study designs that you need to conduct in order to try and answer those questions. You've pretty much got to throw yourself into it full time. And I'd always kind of had the concern of becoming out of date or sort of losing touch with reality in not being in clinical practice. But I'd like to think the 16 years and counting that I've done thus far as a full-time clinician, or pretty much full-time clinician until very recently, will hold me up for long enough that I can throw myself into academia full-time for a good number of years and try and answer some of these questions and then see where we end up.
Yeah, 16 years of more or less full-time clinical life. There's some good learnings and experiences along that journey. That's for sure. That's a good solid innings. And Brad, this term patellofemoral pain or kneecap pain, maybe we start with defining it and a bit of an explanation around the type of symptoms people experience before we touch on just how big of a challenge it can be to certain groups of people.
Yeah, sure. Good place to start. So I think one of the key messages that I always try and get across on when I come on something like this is to separate patellofemoral pain out from some of the other concomitant or sometimes coexisting anterior knee pathologies. You know, we've tried to move away from this term of anterior knee pain because that is a very large umbrella. You know, that's a big umbrella under which patellofemoral pain sits. But I think it's important that we do our best to try and differentiate PFP from, say, patellar tendinopathy or Pezanserine bursitis or Osgood Schlatter or isolated fat pad pain, for example. Typically, we talk about PFP being reflected by pain at, around, or behind the kneecap. But one of the sort of clinical pearls, I guess, is that PFP, compared to some of those other pathologies, tends to be relatively diffuse and poorly localized rather than sort of isolated and pinpoint. So what I often say to students is we're looking for someone who sort of puts their whole hand on the front of their knee and has a good rub around and says, you know, it's in there somewhere. I know it's at the front, but I can't really pin it down, compared to someone who maybe takes a single finger or a couple of fingers and says, I feel my pain here, you know?
That's good. So it's pain at, around, or behind the kneecap. It's often diffuse in nature. certainly do hear that. It's somewhere in there. It's just there, as people put their whole hand over their kneecap, right?
Yeah, can't grab it, can't really pin it down. And then sort of typically a sort of relatively dull and diffuse presentation in terms of the words that patients use to describe their symptoms. And that's not to say you won't encounter patients that talk about sharp pain or stabbing pain, but typically the most common descriptor is usually a sort of dull, diffuse ache that's normally aggravated by activity and generally relieved by rest.
And certain things that typically aggravate kneecaps that are a bit upset, Brad, what might that involve functionally? What sort of activities?
So we talk about anything that loads the knee into flexion. So typically, running without a doubt is a big one. But then other tasks like squatting, lunging, hopping, jumping, up or stair ascent or descent, so going up or down stairs, they're the sort of main four. And if you look at the consensus criteria that are published every couple of years, the big four that we look for that would sort of result in eligibility to come into a clinical trial would very much be those four. But then there's some additional criteria that were added a number of years ago. For example, pain with prolonged sitting, obviously very different to running or to squatting. Again, I use that to sort of demonstrate the breadth and scale of the problem. On paper, PFP can bother your active runner, triathlete, weekend warrior just as much as it bothers the sedentary, inactive individual that sits at a desk for several hours a day. And those two aggravating factors are, completely at opposite ends of the spectrum.
Yeah, that's fascinating, isn't it? And in terms of the actual driver of the pain, it's something that I've heard you speak on in the past. It's been well scoped out in the literature, but what's the current best thinking around what may actually drive this pain? As you said, it's pain at, around, or behind the kneecap, but where's it actually coming from?
The honest reality is that the bulk of work in the field of patellofemoral pain sort of sits in the arena of biomechanics. So if we think about pain drivers or the sort of the primary nociceptive output that would be emanating, we still very much think about an overload of that highly innervated subchondral bone. That's the primary theory around what structure is resulting in that significant nociceptive output. But there are a number of other sort of theories that are being explored, such as other soft tissues being involved, so the patelloretinaculi or the synovial lining of the knee, for example. There's still an ongoing conversation around whether fat pad pain is part of patellofemoral pain. Is fat pad pain a clinical entity that can coexist or sit separately to patellofemoral pain? I think the easiest way to answer that question is we just aren't sure, and it's likely to vary from person to person, and it's also unlikely that any person with PFP or any other gradual onset musculoskeletal condition for that matter has a sort of single pain generator. I think that's probably an unrealistic expectation. Yeah,
I think that's a key point there, Brad, and in some ways it's an academic debate, an academic interest point, as opposed to something that really affects the outcome of the intervention.
Yeah, and I think there are definitely some examples where it may change the management course for the patient. I think it's easy to get into a scenario where, and I do often stand behind this descriptor. We haven't damaged anything. What we're in essence doing is irritating a sensitized tissue, whether if you choose to sort of lean on the analogy of scratching a gnat bite, if you leave it alone for a little while, it will settle. If you keep scratching at it, you'll probably make it worse. But then that analogy falls down when you do encounter a patient who, has a genuine underlying synovitis and may well benefit from a more anti-inflammatory focused treatment, whether it's oral anti-inflammatories or potentially something intra-articular, a joint injection as an example. So I think it's important to understand to try and best understand the pain source, not necessarily for the typical patient, but perhaps more for the patients that sit on the fringes of, is this PFP or could it be something else?
The ones that sit on the fringes, I have a feeling, Brad, I may have been a fringe dweller throughout my life. I had kneecap pain, patellofemoral pain as a junior triathlete. Certainly became one of the statistics that then went on to have, at 40 years of age, more or less more seasons or years of pain with my running and daily activities than not. However, I did have some trochlear groove defects or actual significant size defects in that groove, which maybe I'm one of those fringe dwellers. Is that what you're sort of indicating there? These people that might actually have some type of cartilage lesion that affects the, as you said, sensitive subchondral bone?
Yeah, certainly. So, if we dwell on the sort of on the cartilage issue for a moment, one of the reasons why we're trying to steer people away from this sort of chondromalacia patelli descriptor is that term, by its very origin, if you want to break down the Latin, it's widespread change on the retropatellar surface. Widespread change probably doesn't matter, and it's probably a reflection of age and activity, wrinkles on the inside, if you want to lean on that analogy. But there will be people out there who have got focal deficits in cartilage, be it in the trochlear groove or be it on the retropatellar surface. And dependent on your age and the size and location of that deficit or defect rather, and how stable or not that defect may be, that a large enough defect will have an influence on the surface area we have available over which to bear load. And if you have an unstable defect where lots of chondral fragments are breaking away and getting into the synovial fluid, that could very easily lead to a synovitic reaction within the joint. So another sort of misnomer you often hear that, patellofemoral pain shouldn't necessarily be assessed or treated by a surgeon. And again, for a typical case, that rings true until you have someone who has a large unstable chondral defect that may need a surgical procedure. So I try my hardest to shy away from saying, kind of black and white didactic statements like there's no place for orthopedic surgery in patellofemoral pain. In reality, there's little place for orthopedic surgery in your average case of patellofemoral pain, but that may well be different for that one patient you encounter next week, So
I've had the two trochlear groove defects surgically operated on in both knees, 12 years apart, and I do wonder if I would have got to the same situation with or without the surgeries. It's a fascinating area. Brad, on one of your and your colleague Simon Lack's recent Instagram post, Team PFP, one of my favorite clinical Instagram follows, you'd captioned this: outcomes for people with patellofemoral pain or kneecap pain are currently suboptimal, even with gold standard care. Your group, Brad, Simon and yourself, Brad, want to be at the forefront of obviously improving this. So this might seem like a loaded question, but is it possible with people with patellofemoral pain to truly put it behind them?
I think I'd be cautious in saying yes for absolutely every single patient. I think if you look at the literature that we have, that statistic there comes from a couple of individual cohort studies that were then systematically reviewed by a good friend and colleague, Nienke Lankhorst, who's based out at Erasmus in Rotterdam. And the statistic we often wheel out for introductions or for impact statements in grants, it's up to 60% of people with PFP are still reporting significant pain 5 to 8 years post-diagnosis. So that's obviously a negative stat when you look at it that way around. But then given how prevalent patellofemoral pain is, its high incidence rate, its subsequent high prevalence, lots of people get it, that's still 40% of people that on the face of it have done well. So I think the reality is that some people can do very well when they have patellofemoral pain and they receive optimal care. Conversely, some people do very poorly. And I think it's easy to blame poor outcomes on poor care. But I think the reality is, and I've seen this myself in specialist clinics, as has Simon, there's nothing worse than giving a second opinion, or in some cases, a seventh or eighth opinion when someone comes in and describes patellofemoral pain, describes what sounds like it's good quality, evidence-informed care, and they're still not improving. I think that's the reality. Some people receive good care and still don't improve. And that's borne out in clinical observations from people that see this a lot and the published research we have. And I think if we kind of bring it back to some of the stuff we started talking about, one of my thoughts around the outcomes we observe in randomized controlled trials is that diagnosis or misdiagnosis may have a part to play there. If you look at the cohort studies from our 2018 systematic review looking at epidemiology and risk factors, the incidence rate of the condition, jumps around all over the place in what would otherwise be relatively tightly controlled homogeneous populations. If we look at military recruits, for example, the incidence rate in one study, I believe it's Michelle Bolling's study, is as low as 3%, 3 in every 100 basic training recruits. But then in some of the Belgian studies, Yanni Thijs is the author, it is as high as 45%, 45 out of every 100 recruits. So what explains that variation in incidence? I don't have a definitive answer for you, but I think it's reasonable to expect that the diagnosis or the process of diagnosis is likely to affect that. And therefore, when you take that forwards into an RCT, if you've got a large RCT of people with patellofemoral pain and of your sample of 100, 25 of them are misdiagnosed, it's unlikely that they're going to respond to what you're putting in front of them.
Yeah, so that's going to bias, obviously, the scientific outputs there, and therefore we've got to interpret things with great caution, I guess. What are some of the impacts of symptoms? Because you just mentioned that 60% of people can go on to experience symptoms up to 5 years later. But why does this matter? I know it matters. It's been a big impact on my life, but why does it matter?
Yeah, again, if we look at the observational data we have, when someone has persistent patellofemoral pain, generally over time their activity level will decrease. They either have to change track and involve themselves in activities that they don't necessarily truly enjoy, or they cease or dramatically reduce activity on the whole. So if we think about consequences there for public health in terms of metabolic health, cardiovascular health, body mass, all of these variables that this awful pandemic that we've experienced has kind of really shone a light on. If you have PFP, you're more likely to have poor general physical health. And then the other answer would be psychological status or health-related quality of life. If we look at some of the large cohort studies we have, and there was a really nice systematic review from a few years ago led by Liam McLaughlin, who did a PhD up at UQ in your neck of the woods with Bill Vincenzino. Rates of anxiety, depression, kinesiophobia, etc., much higher in people with PFP compared to the general population. Now, unlikely to be any higher in PFP than other persistent musculoskeletal conditions like low back pain, for example. But the reality is that the health burden of persistent PFP, both physical and non-physical, is there for all to see, really. And
even down to things like career choices and participation, I've read for adolescents in their various future endeavours, it can alter that. People ruling themselves out of certain careers because they know that they'll get pain squatting down or going downstairs.
Significantly so. If we and lean on the military data, if 43% is a genuine figure, that's almost half of every recruit that goes through basic training that's probably going to withdraw from their military career, isn't it? And adolescence is another perfect example. That was one of the things that really struck me from completing that systematic review. The incidence the mean incidence, the average of all the studies, is as high in military recruits as it is in adolescents, and so someone with 2 young kids that I'd like to hope will go on and enjoy lots of sports and continue to be sporty and active for the entirety of their lives. It's a genuine burden in adults and adolescents alike.
I sort of summarise my experiences. I've just learnt to live with patellofemoral pain and to not let it produce anxiety in me now, realising it's not damaging my knees. So it's not pleasant and I wish it wouldn't come back every now and then, but I'm one of those people. I've seemingly tried the evidence-based practices and still haven't had a breakthrough, but I still participate in things knowing that I'm not doing myself damage. Brad, on the activity reduction, in preparing for this, I went back to one of your research colleagues, Dr. Rich Willie's slides, and there were several papers that he'd referenced here that people with patellofemoral pain exhibit up to 3,400 steps less per day, 40 minutes less mild activity, and 10 minutes of less vigorous activity per day. That's quite a reduction.
Absolutely. And then you fast forward a few years, and it will obviously be different for each individual person, but how much time is needed before that reduction starts to result in other health consequences. If you think about the older group who are sort of on the patellofemoral pain, patellofemoral OA borderline, kind of around that big 40 number that I'm closer to than I'd like to be compared to when I started my research journey. The risk of type 2 diabetes and high blood pressure, and the list is endless almost. So that's one of the many kind of statements that we lean on when looking to put in any sort of grant application. What's the impact of patellofemoral pain on wider society? I think you've done a good job there of summarising it for us.
Brad, before we look at some of the treatment do's and don'ts, errors and myths, you touched on it briefly before, but imaging, the role of imaging, you mentioned the term chondromalacia and that it's fairly widespread in asymptomatic knees as well. But can you just speak to the role of imaging in managing or diagnosing, if you like, patellofemoral pain? There's many patients or people suffering that just want to have it imaged because it's been going on for so long. So what's your advice there? What learnings can you impart?
Yeah, it's always controversial, isn't it? Whenever people want to talk about diagnosis and imaging, and a good example of an area where I have to sort of try and temper my research brain and kind of keep my clinical and research hat set aside. I think something that's important to say on this is I think clinicians, researchers too, to be fair, tend to have quite strong views. And I think the mistake we make is that very rarely do we ask patients what they think. I'm loath to give away too much, not because I don't want to, but partly because this paper's not been peer reviewed yet. It's very, very close to being accepted. But we've just finished by the time this goes out, it may well be accepted. It's pretty close. So I'll give a bit away. We've recently finished a series of qualitative interviews with both patients with PFP and sort of clinical academic world leaders that treat and research PFP. And the issue of diagnosis and imaging, really divergent. It's probably the best example of divergence in the data set. Patients are really clear. They want a diagnosis and they'd quite like diagnostic imaging for reassurance purposes. Whereas the experts are sort of fairly strong in saying diagnosis probably doesn't matter and imaging should kind of really only be used to rule out rule out other conditions rather than rule in. An easy way to go about it is if the imaging question comes up is, I think if a patient wants imaging, I think where's the harm? If patients want to be imaged, I think that the potential for harm is poor communication of that imaging, and that's on you as the clinician. If you're going to sit there and say, look at your horrible chondromalacia patelli and you need to stop squatting, running, jumping, etc., there's obvious potential for harm. But if you're a good quality evidence informed clinician, you should be able to separate the wheat from the chaff. I think that the ruling out piece is really quite important as well. So is there anything on imaging that can really help us put the nail in the coffin and say, yes, you definitely have patellofemoral pain? Not so much. But if we think about MRI scan, for example, if someone has a very florid and irritated either synovial lining or fat pad, we can visualize that very nicely on MR scan. Ultrasound scan, we can get a very good look at their patellar tendon, and if they're clear of tendinopathy signs, then we can just be that little bit more comfortable in saying, this isn't a patellar tendinopathy, this is likely to be patellofemoral pain. So I think it helps the ruling out, and it also helps to highlight some of the stuff we talked about back at the start in terms of large chondral defects that may be unstable. It does help to unpick some of those things. And then the third bit is the sort of the structure angle. And this is a slightly incomplete story at the moment. But if we look at the longitudinal cohort studies we have, the most studies that come out of Harvard, that David Felson's group are sort of at the forefront of, and then there's a chap in the US called Joshua Stefanik who's done quite a lot of work in this space as well. People with patellofemoral dysplasia, so whether it's patella alta, where the patella rides higher in comparison to sort of an arthrokinematic norm, whether someone has a shallow trochlea, whether someone has sort of lateral patellar displacement at rest. When people demonstrate these dysplastic features, they're significantly more likely to go on to demonstrate features of patellofemoral arthritis. So one of the many hypotheses we have around imaging is that these structural variables are likely to feed into prognosis and may well sort of reflect a need for a different track. I guess all I've really got at the moment is that someone with dysplasia is likely to rehab slower than someone that's got a structurally normal knee, for want of a better term. My bias is, if I put my research cap on, I'd scan everyone because I'm a nerd and I want to know what the inside of your knee looks like, and I want to know if you're dysplastic or not, and vice versa. I'll temper that by saying I think clinically the best we have at the moment is that if a patient is keen on a scan for reassurance, I think they should be offered one. I think we then need to be careful about how we disseminate those scan findings, and if we use them to help rule out concomitant pathology rather than rule in PFP, you're working from a pretty good slate, I would say.
So the scan or the image is not the problem. It's what the clinician does with the scan and how they communicate about the scan that I think can be the problem, as you just said there, Brad. And linking back the dysplasia of the patella or patellofemoral dysplasia, they are radiographic diagnoses, right? You can't look at someone's knee and say that's happening. I presume that's a radiological ruling.
Primarily, yes. There are some clinical signs. So people talk about a J sign, don't they, potentially reflecting lateral patellar displacement, where rather than tracking in a straight line through an open chain knee extension, someone's patella jumps to the side, jumps laterally. And there's also a clinical sign where in 90-degree sitting, if the spotlight, if you imagine a spotlight coming out of the patella, should be pointing horizontally, and if it's pointing at any sort of angle, it can indicate patella alta. But I'm not sure I'd stand behind the validity or reliability of those clinical observations. So I think they can help steer you towards someone maybe being more likely to demonstrate dysplastic features, but I'd temper caution with actually using them to say, yes, you have a dysplastic knee on your hands.
But if you did want to find out if someone did have a dysplastic knee, it would be imaging. Is that correct?
Yes, and everyone has slightly different approaches to it, but as I understand it, the best approach, particularly in an otherwise normal knee, would be to go for MR as a sort of catch-all investigation. Some orthopedic groups are still very interested in using plain film X-ray, and certainly the skyline view on a plain film X-ray is a really nice way to visualize the trochlea, particularly. But you're then obviously tempering the risk of radiation versus what you can see on an MRI scan. So,
Brad, the causes, what are the known causes of patellofemoral pain?
Yeah, it's a fairly easy question in that we don't really have any if we want to be sort of dead towing the line. The systematic review we conducted a couple of years ago, back in 2018, which is published in the British Journal of Sports Medicine, we identified two variables that had a prospective association with patellofemoral pain. The term risk factor gets some people in a bit of a tiz, and I sort of get why, but I think it's an okay descriptor for what we're talking about here. So in the military cohorts, military recruits that had weaker quadriceps were more likely to go on to develop patellofemoral pain. So we can therefore say that weak quads are a risk factor for patellofemoral pain in military recruits. The reason sort of people get a bit upset by that term is that in order to complete the circle, we then need to investigate that variable. So if we implement a quadriceps strengthening strategy and then observe a reduction in incidence, you've sort of completed that circle, a bit like how we understand that smoking is a risk factor for various diseases, let's say heart disease as an example. A smoking reduction program or smoking prevention program generally has positive influences on then the subsequent incidence of heart disease going forwards. And that's the bit we often end up missing in the musculoskeletal field. But if we look at those data in isolation, would it be sensible to screen military recruits by their quadriceps strength and look to put an intervention in place for those that demonstrated weaker quadriceps? You know, I think there's good scope to look at doing something along those lines. And then some interesting data in the adolescent cohort. We identified that adolescents with stronger hip abductors had a greater chance of going on to develop subsequent patellofemoral pain. And that's when measured isometrically using a handheld dynamometer. And on the face of it, there isn't really an obvious plausible link between strong muscles and the development of patellofemoral pain. So there's a hypothesis, and I think it's important to stress that it is very much a hypothesis at the moment, that because longitudinally adolescents with PFP, initially at least, seem to be more active than their peers, it could be that what we've measured is their hip strength, but their hip strength is actually a proxy measure for the amount of activity that they do. So there's this hypothesis that activity level across the board may well be a risk factor for patellofemoral pain. And that those adolescent data, certainly, you know, I would say that has good biological plausibility to look at investigating activity level as a risk factor in adolescents. And I think that stands true as well for recreational runners, triathletes, you know, arguably anyone with patellofemoral pain. But I often see people speaking with great confidence that activity level is the reason people get patellofemoral pain. And we just don't have those data at the moment. You know, it's a big area of research need, but I'm still sort of cautious with how strongly I stand behind that, because the prospective work just hasn't been done. And you know, I'm sure you would agree with this as well, with the group that you often see. Elite runners who run an awful lot very, very rarely get patellofemoral pain. There are plenty of runners that run an awful lot, whether elite or otherwise. They do an awful lot. They violate the colloquial rules of training and workload management, but outwardly they don't seem to break down with PFP. So I think activity level is likely to be no different to any other variable. And I suspect some people, for whatever reason, can probably run as much as they want and do however much they want, whatever intensity, however long a rest period or an off period before they go back to it and be okay. Other people are probably very sensitive to changes in training load and need to be careful. But at the moment, I say we don't really have a clue who's likely to fall into which bracket.
So it's fascinating. And certainly an experience I've had is whenever I've personally had some sort of net change in my running workloads, but also my cycling workloads over 30 sort of years around triathlon, I tend to be more sensitive to a flare. And I might be getting down on the floor with my kids and be like, why is my knee sore today? Why are my knees sore today? And then I reflect and go, well, it's because you had a bone stress injury and you stopped running whatever kilometres or miles a week, and now you're cycling this many kilometres with incline. So it does tend to be a trigger for me personally, Brad, and that is that change in activity level. Not so much the overall activity level, because I've had pain-free knees when I've run my biggest weeks, but it does tend to be for me that sensitivity around changes in the workload.
Yeah, and I think one of the many difficulties, and this is a slightly sort of research methods answer to the question, but the reality is, if you look at the prospective cohort studies that we have, there's a study from out in Scandinavia. Ramskov is the lead author, which identifies that runners with weaker hip abductors were more likely to go on to develop PFP in the first 50 kilometers of a start to run program. If you think about the sort of clinical dogma, for want of a better term, lots of people would jump on that because, if you can give people stronger hips, physios love giving out hip strengthening exercises, you can reduce the likelihood of someone getting PFP. Everyone kind of starts cheering. But if you look at that study design, there was no control over how quickly a runner got to 50K. So as a result, it means that hip strength becomes a dependent variable, and the independent variable, the thing we're not controlling, is how much running someone is doing. And that's the bit that's missing. So what we need are a prospective cohort studies that maintain running as a dependent variable so that other things can remain independent. And they're difficult to do because prospective cohort studies are hard to recruit to. They're time consuming and costly to run. And if I said to the average runner, okay, for the next 6 weeks, I'm going to take an average of your Strava data for the last 6 weeks. And for the next 6 weeks, you're just going to do that. I don't want you to increase. I don't want you to decrease. I don't want you to change your intensity. For the next 6 weeks, you're just going to stay here. A lot of runners, my hypothesis would be that a lot of runners will go, nah, you're all right, mate. I've got a race in 6 weeks and I need to go up. So it's really hard to understand in isolation how much these variables matter. I draw on, kinematics, and we look at the cohort study from Brian Noren's group back in the early 2010s, which identified that female runners with a more adducted hip were more likely to go on to develop patellofemoral pain. Now, we have to be cautious with these data because it's a relatively large cohort, sort of 400 and something runners, that looked at a number of kinematic variables, but they had a very low number of people in the outcome group. One of the things you can't control for when you do a cohort study is how many of that sample are going to go on to get patellofemoral pain. You can hypothesize, but you can't guarantee. And they ended up with a very low number relatively of people with PFP. So the risk of bias in that data set is higher than we would like it to be. But again, if we take it at face value, the female runners with a more adducted hip were more likely to get PFP. And why might that be? And chances are, again, one of my many hypotheses would be that it's unlikely to be a univariate association. It's unlikely to mean that variable A results in PFP. It's much more likely that for patient X, variable A, B, and Z are the reason they get PFP. So someone with a more adducted hip that has a dysplastic knee that violates their workload rules, their risk increases. Someone with a normal knee with good muscle strength who trains sensibly might be all right. So again, methodologically, what we need are very large cohort studies with enough data to allow us to do some proper exposure modeling, some proper network modeling so that we can try and understand how all these variables fit together, because it's highly unlikely to be that two variables line up in a perfect way.
Brad, one of the perhaps most widely spread beliefs, if you like, around kneecap pain is this idea of maltracking of the patella or your knee's maltracking. It's certainly, when I was growing up in the 90s, receiving physiotherapy care as a junior triathlete was the reason that I was informed that I had kneecap pain was because my kneecaps were maltracking. So I thought, well, simple, I'll make them track properly then. What have I got to do? 30 years later, I don't think I've solved that one. But Brad, what would you say to this idea of maltracking? You've already mentioned these certain individuals that may have a dysplastic kneecap, but what about this idea of maltracking because the inside of the quadricep muscles are insufficient, etc.? The good old VMO.
Good old VMO. I think that's one of the sort of historic theories that we can probably start to put to bed now. I don't know if I'd tuck it in completely, but I think it's definitely one of the theories we can start to put to bed, in that if someone does demonstrate maltracking, it's highly likely to be structural in nature. It's likely to be their bony geometry that drives it more so than the function of their muscles and subsequent control. And therefore, the theory around strengthening VMO and the lateral release procedure, or whether surgical or otherwise, that's a theory that we can sort of probably start to put to bed. But then perhaps, and there's been some interesting ultrasound work looking at the pennation angle of the VMO and its ability to influence patella arthrokinematics. It may be that there are a group out there that would benefit more so from some targeted quadriceps strengthening in the same way that the adduction, the kinematic adduction piece, seems to be a phenomena observed significantly more so in females than in males with PFP, but perhaps at the same rate that you would observe it in the general population. If you go back to the late 80s, early 90s, when biomechanical studies were looking to identify just the difference between healthy men and women, healthy women generally demonstrate a more adducted hip during walking and running than a healthy man, because we have different skeletal geometry. It's basic biology. It's whether these differences are significant enough to either be either a predictor of onset for a pathology or a predictor of response. We published a case control study in the Journal of Biomechanics as part of my PhD, 2019, where we had 4 groups. We had men and women with and without PFP. And for adduction, we identified no difference between the male and female controls and the males with PFP. But for about 80% of stance phase, so from the point that the foot hits the floor to almost the point where the foot starts to leave the floor, the females with patellofemoral pain demonstrated a greater degree of hip adduction compared to those other 3 groups. So if we think about something like gait retraining or movement retraining, where we're trying to alter how someone moves, if you're doing that in a female with a significantly more adducted hip, you might be along the right lines. For someone like you or I, it may not be the right strategy, and these are, it's one of the many things we need to try and understand to a better degree.
So touching on there, some interventions for helping people, Brad, with patellofemoral pain, I think it might be fun to explore one of the posts that yourself and Simon shared on the Team PFP Instagram gallery, and it was from the 5th of June, and it was titled 5 Common Errors in Kneecap Pain Rehab. And if we may, let's go through the 5, because I think it brings up some good talking points. The first one was too many thigh exercises. Strong quads are an important part of the rehab process, but strengthening the glutes, hips, is better at reducing pain and increasing function short and medium term, you state.
Yeah. So, and this review has been sort of repeated a couple of times now. It's probably repeated more often than it needs to, if we're completely honest. But back in, I think, 2016, Simon systematically reviewed the literature on proximal, so hip or local quadricep strengthening. And what the review identified, in essence, was that both quadricep strengthening and hip strengthening are effective. It sort of appears that hip strengthening may be more effective than quad in isolation, but when you combine the two, that's probably where the magic happens. So if we think about the maltracking theory, there are, I would imagine, well, I don't imagine, I know, because I've seen these patients, and I'm not for 1 minute suggesting that I get everybody better, or that no one has ever seen a patient of mine that hasn't got better, because I'm not that blind. But the reality is, you will see patients in clinical practice who have been having care elsewhere, and their focus is purely on their quadriceps. And, it's unlikely that every patient you see is only going to need a quadricep strategy. I think that the bulk of people are more likely to require a combination of the two. So patients that are focusing purely on their quads and not even thinking about whether the hip is involved, again, they're probably onto a bit of a loser, I would say.
Which kind of brings up the second error, and that is not enough thigh exercises. Maybe an overfocus and reverse at the hip. Yeah,
absolutely. Or kind of, we all love chucking the baby out with the bathwater, don't we? And we all love running with trends. And, because our understanding around the influence of the hip has increased so much over the last 10 years. For some people, that's resulted in it's all about the hip, and the actual knee itself doesn't matter. I think of in the months before I stopped my clinical practice, I saw a competitive powerlifter who had a long history of PFP, and I was probably the third or fourth person he'd seen, and things weren't going so well. Similar to yourself, he had a fairly chunky defect in his trochlear groove, which had been calmed down with a reasonable amount of bone edema around it. It had been calmed down by an injection. And the clinician he was seeing previously, everything was focused at the hip. He came in, he said, I'm doing heavy loaded hip thrusts, I'm doing stiff leg deadlifts, I'm doing fire hydrants, crab walks, I'm doing all this hip stuff, and it's just not going anywhere. And in the privileged position that I was in, pulled out my dynamometer and showed him that unilateral pain as well, pain on his left knee, showed him that actually in all directions, his symptomatic hip was exactly as strong as his asymptomatic hip, but he had a whopping great quad deficit. We spent 12 to 16 weeks working on trying to optimize his quadricep function, and he did much better. And from memory, he's still, I've passed him on to Simon, who's still in clinic at Pure and continues to do well. But a nice example of where someone's taken the emerging literature and gone, okay, well, it's all about that now, and forgotten that actually the other bit still exists. And for certain patients, that other bit that still exists might be the bit they need.
Brad, the third mistake that people can make in trying to rehab kneecap pain, you state, is ignoring shoe inserts, or as your colleague Ian Griffiths so eloquently educates people, orthoses. So what can you share around that?
I think this is probably the easiest example of where someone could make such a significant change to their practice. Foot orthoses, whether customized or prefabricated, and the reality is studies use prefabricated orthoses most of the time, because orthoses companies are pretty good at coming along and saying, here's a big bag of our orthoses that you can use in your study, and don't need to spend any money on them. We know that they're more effective than nothing. If you look at Cat Mills study from 2011, wait and see control versus prefabricated foot orthoses, significant response in the group that received the orthoses versus the group that received no care. So confirms that notion that PFP is not self-limiting. If we don't treat it, people are likely to stay the same. But then in receiving an orthoses, significantly better than no care. The number, and this is a statistic I really like for clinicians, the number needed to treat, the lower the number needed to treat, the better. What it essentially reflects is how many people do you need to treat in order to have a dumb luck chance of getting them better. And the number needed to treat for orthoses is 4. It's really low, right? It's super low. And then we look at Nat Collins' follow-up work, which was a 4-arm RCT, sham orthoses, and physio in isolation. The orthoses group did better than no care once again, but in this case, there was no benefit to adding orthoses and physio together. And that sort of fed into the largest RCT we have in PFP at the moment, which Mark Matthews conducted as part of his PhD, again, up the road at UQ. The guys at UQ generally do some very good work in this space. 2 different groups, a hip strengthening protocol, a foot orthoses intervention, no difference between the two. So orthoses are better than nothing. And on paper, they're as effective as exercise. And if you take the average patient and offer them an orthoses for their shoes that requires absolutely no effort on their part versus a 20-week-long rehab program, which one are they going to pick? Now, we can get into the secondary benefits of exercise, which I would agree with. But I think, again, there's a huge misnomer around orthoses in that they're passive and therefore we shouldn't use them. And people become reliant on them and they result in their feet getting weak and all of these things that just don't have any supporting evidence whatsoever. So certain patients will do really well with orthoses. And if you're not even considering it, you're definitely not abiding by the most recent evidence we have.
And orthoses being worn in day-to-day shoes or just sports shoes? I mean, it's a broad question, but clinically, what would be your advice to people there, Brad?
I think you can answer that question at the moment purely by observing when people get the majority of their symptoms. So if it's day-to-day in their dress shoes, when they go up and down stairs at work, get them in there. If they're fine day-to-day and they get symptoms when they're running or when they're in the gym, as an example, that's the priority. Again, I think one of the key things to look at from the orthoses studies, people are really quick to sort of say, oh, they're prefabs, they're not customized. But the reality is they're customized for comfort. So patients are often given 3 different devices to try, a soft one, a medium one, and a firm device. and they pick the one that's most comfortable. And then it's often further modified for comfort by adding things like a heel raise or a first ray cutout or a metatarsal dome or something like that. So they are modified for comfort. And if people find orthoses comfortable, then they're likely to use them the majority of the time, aren't they? So I think that can be really patient-led. And I don't think there's anything wrong with someone using orthoses day to day, even if they're only symptomatic in certain situations. And from there, it becomes a symptom response thing as to there's this other misnomer that, you've got to get them out. They only work for 6 weeks and then you've got to get them out. And it's like, well, what we actually observe from these data sets is that they're most effective in that 6 week window. If they're going to change pain, it's going to happen in that 6 week window. But that doesn't mean they have to then be taken out. That again, I think becomes a conversation between you and the patient. If the patient's comfortable and doesn't mind wearing them, where's the rationale to take them out? If the patient's saying, actually, you know what, these things are starting to bother me a little bit, I'm not sure I want to keep using them. Okay, let's start weaning them out. And if your PFP keeps behaving, fine, you can chuck them in the bin. If your PFP comes back, maybe we need to get them back in there. It's symptom by case response, I think.
Yeah, that's some great practical advice. Brad, the next mistake that you cite is commonly made is not using tape-in bracing. And I have to reflect on my personal experience with experiences as a PFP sufferer over my lifetime. Personally, I gave up on taping my knees a long time ago. I think I persisted for the first few weeks after I saw my therapist when I was a junior triathlete. But what's the error that people may be making here, Brad?
I think it's very similar to the orthoses argument, really, in that there will be some people that just refuse to go near taping or bracing for similar reasons. It's passive. People will become reliant on it, et cetera, et cetera. That for me becomes, again, a little bit like the imaging piece. So my analogy for taping with patients is it's like taking paracetamol for a headache. If you've got a headache and it's significant enough, you're going to take some paracetamol. Maybe you'll go to bed for a few hours and then chances are you'll wake up feeling all right. You're not then going to feel the need to use paracetamol for a number of other days in case your headache comes back. So if someone comes in with significant irritable pain, and the line you draw for what warrants severe and irritable pain is up to you and your patient. But if someone's in significant pain that is irritable, the evidence reports that taping may well help them. My argument would be try it and see if it changes their pain. Someone comes in and says, if you came in to see me and said, look, mate, I've had PFP for 20 years, it grumbles away in the background, I'm in pretty good control of it, I'd just like to try and gain further improvement, I'm probably highly unlikely to suggest that you tape your knee. But if you came in and said, look, I've never had this before, but I've, done X, Y, and Z, and, this is really sore, it's hurting at rest, it's probably a 7 out of 10, it's taking a good couple of hours to settle. Okay, let's see if we can calm that down for you, If you look at the bracing side of things, so a fabulous was PhD student, now a postdoctoral researcher down at La Trobe with Christian Danilo de Oliveira Silva, ran a lovely straightforward RCT looking at just a simple neoprene sleeve, just a pull-on compressive sleeve with a patella donut. And Danilo's got a big interest in kinesiophobia, particularly during functional tasks. And just with this application of a simple neoprene sleeve, people become less kinesiophobic. They're more comfortable bending their knee. They're more likely to move in a non-antalgic way. And, particularly female patients when descending stairs, which is a group that this is common in and a task that's common to aggravate. So again, it may well be a passive intervention, but it's simple and it results in a change in something that clinically really matters. So
very practical. Brad, the fifth mistake that people can make in trying to treat their kneecap pain, or practitioners, I think is a huge area. And I'm so pleased it's included from my personal experience and professional experience, and that is not considering your psychology. And yourself and Simon state in this post, people with kneecap pain are often afraid to move, have low quality of life and depression/anxiety. Your treatment should consider these factors and address them if needed. It's okay not to feel okay. You will have had this. I've certainly had it in my 15 years of clinical life. people in the consult room in tears because of the effect of their kneecap pain on their aspirations, on their current daily functions. It's often a very challenging thing to navigate.
Absolutely. And I think, unfortunately, it's improved significantly over the last sort of 5 to 10 years in PFP. But if we're honest, we're probably a little bit further behind, say, low back pain in the sort of wider adoption of a more biopsychosocial informed approach to care. But in the same way that we've understood these variables in low back pain, we're very much seeing, as we said, the influence of patellofemoral pain on health-related quality of life, anxiety, depression, fear of movement, etc. It may well be, and again, I'm as cautious here as I am with the kinematic literature or the exercise literature, for example. The bit we don't yet currently understand is the chicken or egg question. Are people with anxiety and depression more likely to get PFP, or are people that develop PFP more likely to be anxious, depressed, afraid of moving, etc.? And therefore, what bit do we need to try and treat? I suspect there may well be a group out there for whom treating their psychological features may well result in changes in physical pain. Whether I'm best placed to do that or not, I couldn't necessarily say. I'm hopefully about to. One of the really nice things about the University of Essex, where I am now, is we're really encouraged to collaborate cross-faculty. So the physiotherapy team that I'm with is part of the School of Rehabilitation, Sport Rehabilitation and Exercise Sciences. We have another school called the School of Health and Social Care, which is where our clinical psychology department are. And we're hopefully about to start collaborating on a simple RCT where we look to see if patients with PFP that demonstrate these psychological features respond better to an education intervention, which is purely based around PFP or an addition of some psychologically informed care. And I think it's a huge gap in the literature.
Yeah, wow, fascinating. And so there may be times when someone would benefit from or often does benefit from a multidisciplinary team approach where it may be required to receive some psychological input alongside some physiotherapy and obviously podiatry, as you've already referenced, if it's not the physiotherapist, for example, or the practitioner going down the orthoses route.
I think without doubt, and in the same way that we understand that, if we kind of think really black and white for a moment, the quad weakness seems to come before PFP. It's still there when someone has symptoms, and then hip weakness comes along as well. We don't have any prospective data that sort of suggests that hip weakness comes before PFP, but it's definitely there when someone has pain. So it's probably a consequence of their change in activity, but we still treat the hip weakness. We still, or the altered hip biomotor function, if we want to be really technically accurate, we still prescribe an intervention around that variable that didn't precede the onset. So even if someone does not have anxiety, depression, or fear of movement before their symptoms, they develop PFP, their PFP persists. We then treat the physical stuff, but I think it's easy to say, they're anxious and depressed and afraid of moving because they're in pain. So we'll just focus on this and then all of that will get better. And that may well be the case, right? A couple of years ago, I experienced a horrendous cervical radiculopathy. I've never experienced pain like it, and it made me anxious, depressed, and afraid of moving. But all of those symptoms got better when my pain improved and I could go back to doing the things I like doing. And that may well be the case for some people with PFP. But my hypothesis would be that there are a group out there who, because they become anxious, depressed, and afraid of moving as a result of having symptoms, those psychological variables then go on to moderate their pain. And if we treat them, we may well see superior changes in pain and function.
You're listening to Dr. Bradley Neal, specialist musculoskeletal physiotherapist and lecturer, sharing around patellofemoral pain best practices. Support for today's show comes from Polar. Polar are a sports technology company who build world-class heart rate monitors and GPS watches for people who take their health, fitness, and sports performance seriously. Polar have an incredible heritage. Headquartered in Finland, they have been the global driving force behind scientific wearables for over 40 years. They are the pioneers in and the world leaders in heart rate measurement technology. Coming from the heart of the Nordics, Polar have the experience, insight, and the history of quality, design, and innovation, which is unparalleled. Polar is worn by some of the best endurance athletes on the planet, and we're so excited to have partnered with Polar so you can also access their heart rate monitors, watches, and training platforms. And just recently, Polar's best just got better with the brand new Polar Red Vantage V2 watch. This watch is stunning. It's the pinnacle of sports technology design, sleek on the outside and smart on the inside, and lighter than other premium multi-sport watches. Polar's Vantage V2 is all you need in one uniquely lightweight, precisely engineered package. So jump over to polar.com, and whilst there, be sure to take advantage of the very generous offer from the great team at Polar, up to 15% off selected products by using the code TPPS. Support for today's show also comes from the Physical Performance Show's very own Learn-Ins membership. If you enjoy the learnings of the show, then there are plenty of learnings in store for you as a Patreon supporter of the show. It's simple. Jump over to patreon.com, search for the Physical Performance Show. There you can pledge your support from just $5 per month. Now, in return, we'll grant you access to our back catalogue of our live stream events, including Dr. Stephen Seiler, forefather of polarized training, Dr. Shona Hallison, world-leading Australian-based recovery expert, and our recent live stream event, Fueling the Endurance Athlete, with UK-based and acclaimed sports dietitian Rinny McGregor. What's more, you'll also receive free access to all of our upcoming live stream events, all from just $5 per month. To become a Learn-Ins membership patron, jump over to patreon.com and join our growing list of patrons. And a massive thank you to our new show patrons, Bernardo Aspen and Kate Walsford. Thank you for your support. Support for today's show also comes from Pogo Physio's online telehealth consultations. If you are an endurance athlete struggling with bone, tendon, or joint-related concerns, then rest assured Pogo Physio's online consultations can help get you back to your physical best. Listeners of the show from worldwide and interstate within Australia have enjoyed getting back to their physical best. To schedule your 45-minute online consultation, jump over to pogophysio.com.au/telehealth. For now, let's jump back with this week's expert edition featuring UK-based specialist musculoskeletal physiotherapist and lecturer Dr. Bradley Neal, sharing around the current best practices for patellofemoral pain. Brad, barriers to effective rehabilitation. You've touched on some errors. An example I've personally, and my bias of N=1 here, but experienced in trying to strengthen my quads is a lot of the time the exercises I've tried over the years, whether it's open kinetic chain, leg extensions, or closed squats, are painful for my kneecap. So I've probably inadvertently biased some hip strengthening over the decades because it's not painful typically, almost lost a little bit of confidence and desire and mojo to pursue the quadricep strengthening because most things tend to trigger it. So any sort of tips you would have it's a big area, obviously, exercise prescription, but go-to exercises or tips around strength and conditioning processes for people with patellofemoral pain?
So I think and you're absolutely right, for a lot of patients attempting to do quadriceps loading, whether closed or open chain, when symptoms are irritable, is often a non-starter. People struggle to engage because of pain. So if I think about a typical clinical journey when someone comes in with either initial symptoms or an aggravation of historic symptoms, starting at the hip is often a good strategy. One, because we understand that people with PFP often demonstrate hip function changes, and if we prescribe exercise around that, we can often have a shot at getting them better. But it also allows for a degree of calming things down. So if you think about fire hydrants, crab walks, hip thrust, deadlift, whatever your poison is, you're not really loading the knee into flexion if you prescribe correctly. So you can allow that knee to calm down. You can keep someone active. You can start to target that motor deficit that they have at the hip. And then after a period of time, when things calm down, then you can start to bring in some quadricep strengthening alongside it. Now, how you go about that, I don't want to sound like a broken record. It's individual for individual people. But I think similar to the ACL literature and many other arenas, there's a sort of low back pain and fear of heavy lifting, for example. I think there's a natural sort of misnomer that open chain loading is more likely to be provocative, and it sort of stems from our understanding of biomechanics, in that joint stress is typically higher in an open chain scenario than it is closed chain because of the different moment arms and lever positions. But some people with PFP and the power lifter I described earlier was a really nice example of this. He got on absolutely fine with a loaded leg extension. Didn't seem to phase him. So that's where we went, and then slowly but surely we started to bring in some heavier closed chain loading. People are often sensitive at a particular point, and you will find, for example, that certain people tolerate being in a deeper position of loading. So if you think about something like a lunge or a Bulgarian squat, you can just get them to work in that deeper position and back up and down, and then slowly but surely take them through a fuller range. Conversely, some people are okay in very early ranges and struggle to go deep. So things like box squats, where you have a natural stop point to take away the bounce at the bottom. Forward trunk lean is another strategy. If you change the position of the trunk, you change the position of the knee relative to the center of mass, you affect the moment arm of the knee joint. All of these things can change the sensitivity of a person to knee joint loading. And a bit of trial and error and identifying the optimum strategy for each person, I think, is the best we have at the moment. I suppose one other thing to say is I think people shouldn't be afraid of bringing in some of those additional adjuncts at that point if you need to. So whether you choose to go for muscle stim, or whether you choose to think about blood flow restriction, ways that you can get adaptation through lower load is another way of going after it as well.
There's some great exercise prescription tips and ideas there, Brad. What tips would you share for the runner suffering from kneecap pain, or, as it's so oftenly cited, runner's knee? What tips would you suggest could be effective for the running cohort out there?
I don't necessarily feel as though runners need to be treated drastically differently to a typical patient with patellofemoral pain. I think the rough way I would go about it clinically is that if someone demonstrates significant motor weakness, then I typically go there first. And you know, there's a growing understanding of the role of strength and conditioning for performance from a running perspective. So more and more endurance runners are being comfortable with getting in the gym and doing something other than running, which isn't a bad thing. And if someone comes in demonstrating quad weakness, hip weakness, the stuff we talked about, then that's a good place to start. I still think there's benefit of a gait analysis, but from a relatively simple metric, you know, so a sagittal plane view, so looking from the side on and looking purely at stride length. You know, if we lean on some of Chris Napier and Chris Brammer's work on overstride and braking force, and some of the work we've done on adduction, female runners, and then Rich Willey and Irene Davies and Brian Noren's work on gait retraining, cadence retraining. If a runner's demonstrating a significant overstride, if they're landing with a foot well ahead of their knee joint rather than the foot planting nicely underneath the center of mass, I think there's a role there for some manipulation of cadence, definitely. But in the same as all of these other interventions, to see if it changes the severity of their symptoms. You know, I would be hesitant to say that run retraining has got the ability to prevent PFP, because those data aren't there. And there's the continued argument of, once someone's symptoms have settled, Can they go back to their old gait, or do they want to stay where they are? I answer that question in a similar way to the orthoses question, really, is that you don't see elite runners overstriding. And when you do some cadence manipulation with a runner, you often, once there's that initial washout period, you often make them more efficient because you optimize their stride length and cadence. So most of them don't want to go back because it feels quite alien because you've made them more efficient. So I think there's a definite role for a simplistic gait analysis to look purely at stride length and cadence and sagittal plane variables. I think the other thing that would ring true would be the orthoses argument, and it may not be a definite introduction of orthoses, but it could potentially be a manipulation of footwear. Again, I think some runners could probably run in the box and get away with running in whatever they want. Some people are probably more shoe sensitive than others, and involving someone with good knowledge around running shoes or a sports podiatrist would be a good place to start.
Brad, I'm just curious, before we throw you the 2 set questions that every guest gets thrown, before you shifted across to full-time academia, how would you start a conversation with someone in a room who you've diagnosed with patellofemoral pain, knowing that there's a possibility that they may not have a great outcome in X amount of period in 5 years? They might be one of that 60%, for example. I find it quite an interesting presentation in that some people do tend to have persistent symptoms, and despite best practices being deployed, can still be symptomatic, unlike many other conditions where you can be relatively confident of a good outcome. Any tips to the clinician out there on how to counsel patients appropriately to not overpromise, to actually paint the reality of the situation that we're faced with?
I'll try. I think initially explaining what patellofemoral pain is, I think is really important. I think kneecap pain is the best descriptor we have for patellofemoral pain. I think saying kneecap pain is probably the best place to go. And then I normally start by explaining where the patella is, what its job is, and how roughly I'll try and use patient language, where the kneecap is and how the kneecap orientates with the groove on the front of the femur. I give an explanation around surface area and how the amount of area we have available contributes to how sensitive the joint may be to things we do, whether it's running, jumping, cycling, whatever it is. And then I try and then give as good an understanding as I've got as to why I think that person may be here. So whether that's a sudden change in the activity that they do, a change in the amount of activity they're doing, the structure of their joint, the way their joint moves, and the way their muscles function. And then rather than sort of initially having a conversation around outcomes, I tend to sort of paint the journey more so for them. So if we've got a runner, let's say, for example, I'm going to say for this initial 4-week period, I'm either going to ask that you don't run for a period of time, or I'm drastically going to reduce your volume for a period of time. We're then going to focus this next 4 weeks on trying to change the strength of your hip muscles, and then we'll start to bring in some exercises around your thigh muscles. At that point, if your day-to-day symptoms are doing well, I might ask you to do a short run on my treadmill where I'll get a little bit of footage and see if there's any benefit in us looking to change how you run. And then from there, we can phase you back into running with a continued focus, a renewed focus on what you're doing in the gym. And then once we're over that cycle, then we can start to think about your longer term running plans and getting you from where you are now to where you want to be. So I sort of generally give them a rough guide for how that initial 8 to 12 weeks will go. And then from there, we've got that wiggle room based on how they respond. But I typically say this is going to get better over months rather than weeks. And the mistake that a lot of people make is that they kind of crack that initial nut and then think they're all right. And that's what's likely to get them into that boom and bust cycle. So sort of giving them that spiel of the short-term sacrifice will be worth it for the longer term benefit.
Oh, gosh, so practical, Brad, and very helpful. Brad, every guest of the show issues listeners with a physical challenge for the week. So what is Dr. Brad Neal's physical challenge going to be?
Oh, you put me on the spot now. What would I go for? I'll go with something that tells you a little bit about me. So having gone to university on a swim scholarship and swum for a number of years, I've since hung up my goggles, and I'm now a very, very, very average runner, purely for fitness purposes. But my main sport is baseball. My challenge for you would be, whether you've got a glove or not, grab a friend, grab a ball, and go and have a throw for me. See what it feels like to turn your arms over.
All right, that's a first for the show, Brad, but a nice, unique one there, obviously. And Brad, if you had to boil everything you've learned through your career to date, clinical, academic, into one piece of advice to help listeners of this show just broadly perform at their own physical best, what would Dr. Brad Neal's solitary piece of advice be?
I think this applies to patients, it applies to clinicians, it applies to researchers as well, academics. I'd like to see more and more people being ever more comfortable with the very grey world that we exist in. So one of my aims when coming on and doing something like this, or speaking at a conference, or talking to a group of students, is I'm always as tentative as I can be to giving definitive didactic answers. I think we've got very, very few definitive answers for few things in life, but particularly when it comes to physiotherapy and patellofemoral pain and musculoskeletal health. So I think if we can all step back a bit and accept that perhaps we don't know as much as we maybe would like, I think we'll be on a path to some greater understanding. You know, if I had a tenner for every time someone came in and said their back pain was their mattress, or their PFP is their shoes, or, you know, it came on because I didn't stretch after I went for a run, you know, nothing in life is that straightforward. So stop focusing on those minutiae and be a bit more comfortable in the grey.
Well, that's very reassuring for me to personally hear, Brad. I think my clinical life is getting greyer every day, every week. So thanks for the reassurance, Brad. For those that want to find out more about your work, about workshops that yourself and Simon provide, where can they go?
Best place would be our website, I would say. So www.teampfp.com. We're also on Instagram, as Brad has mentioned, at Team PFP, where we aim to share. We use Instagram as a sort of knowledge translation platform to try and share our work and work of others. Both, you know, we probably do more clinical stuff than we do patient stuff. We try and do. And we aren't doing enough patient stuff at the moment. That's something that we will aim to change. I'm also on Twitter at Dr. Brad Neal. And coming up in mid-November, if you're interested, we're doing a 4-hour online webinar as a collaboration with Trust Me Ed. There's some pre-recorded online videos to watch, and then there's a live 4-hour practical webinar with Simon and myself. We've aimed to do it at a time zone that will fit the various time zones around the world. I think it's 1 p.m. GMT from memory, so it'll kind of be later for you guys in Australia and a bit earlier for the guys in America. But yeah, if you're interested in some practical application of some of the stuff we've talked to today, then have a look on our website or click the link in our Instagram bio and you'll get some more info there.
Yeah, brilliant. And it's a must follow page, at Team PFP on Instagram. Dr. Brad Neal, thank you for your generosity with your time and your contribution to the Physical Performance Show.
Thanks, mate. Pleasure to be invited and good chat and good to see you.
So there you have it, another episode of the Physical Performance Show, and I trust and I know you enjoyed today's expert edition. If you did, then please jump over and let Dr. Bradley Neal know what it was that you enjoyed from his share-ins. You can find Brad and his colleague, Dr. Simon Lack, over on Instagram at Team PFP. There they do a great job on bringing us all up to speed with the best practices for patellofemoral pain. You can also find and follow Brad over on Twitter at Dr. Brad Neal, Neal. And of course, the show notes over at pogophysio.com.au/podcast. Keep the podsies coming, team. That's simply a screenshot of the episode that you've been enjoying. and tagging in the show at Physical Performance Show over on the socials. It's also our annual feedback time. You can go into the draw to win a $50 Amazon gift card simply by completing our brief survey, which you'll find on our bio link over on Instagram. As Prior mentioned, if you've been enjoying the show, please consider becoming a patron of the show. We'd love to grant you complimentary access to our back catalogue and all upcoming live stream events to help you continue with your learnings around pursuing your physical best performance. And of course, it practically helps us with the production of this show. Speaking of production, thank you to the great folk who continue to make this show possible each and every week, all the way back from episode 1, the original team, Daryl Misson, our audio engineer, Susan Wilkin, show administration, and Matthew Walding on all things show graphic design. Now, coming up on next week's episode of the Physical Performance Show, as most of you will be aware, we recently featured UK-based sports dietitian and author and former guest of the show, Rinny McGregor, on a live stream event. It was attended by registrants worldwide, including coaches, athletes, and practitioners in the sports and exercise science fields. And next week, you'll enjoy a sample from the live stream of Rinny answering just some of the plethora of questions that she fielded. It's an important topic for all athletes, coaches, and practitioners to be across, so be sure to be tuning in next week with Rinny McGregor, Fueling the Endurance Athlete Q&A. Until then, keep pursuing your physical best performance. I'm Brad Beer, and this has been the Physical Performance Show.